Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm Gillian Whiting and I'm your host, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr. Maria Bolton, GP specialist and former president of AMA Queensland.
Today we're joined by Professor Mike Reid, Orthopaedic Surgeon at Mater Private Hospital Brisbane and Mater Private Hospital Springfield. Mike, welcome to sMater.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
What are the most common acute knee injuries that you're seeing at the moment?
Well, I mean, there's been a bit of an expansion in knee injuries. I look after a lot of female sports players, and actually there's been a big expansion, obviously, in female sports. They advocate the introduction of a lot of professional sports, and we look at the Women's World Cup in rugby at the moment, Women's AFL League, the massive expansion. And as a result, there's been an expansion in particularly women's knee injuries, and particularly women who go cross codes. So they've been maybe a runner before and then go into a pivoting sport. We see quite a significant increase in those kind of injuries at the moment.
And do women get different sorts of injuries to men?
Women are built slightly differently, generally slightly wider hips, particularly when you get beyond puberty, slightly narrower knees. So there's a tendency to valgus or to be slightly knock-kneed in women or more commonly in men. And in terms of particularly when you get women who go cross code, so haven't necessarily done pivoting sports before, been excellent runners, but then come to cross sports because there's professionalism in that. And they maybe don't have the same training or muscle build-up as they may have done had they played that sport from a younger age going up. There's also some evidence with hormonal imbalances, and where during the menstrual cycle there may be hormone imbalances that lead to ligamentous relaxation and may increase the types of injuries that women may receive. So we're seeing that's why we're potentially seeing, and it's a multifactorial thing. Why exactly does it happen? There's lots of research going into it now because there has been an expansion and doing things like training, like the FIFA 11 Plus program in a prevention kind of way to be able to reduce potentially these incidents or injuries.
Australia has the highest rate of ACL reconstructions globally. What's driving this trend, or are we just really good at diagnosing it?
Well, I think there's higher expectation. We've got much higher sporting participation as well. So there's a lot more codes available. So we've got, AFL, rugby league, rugby union, football, or footy, as everyone says. When everyone injures them, they come in. It's always difficult to try and pick what sport they play because everyone injures it doing footy. Also, we have a greater accessibility, you're absolutely right, for diagnostics. So in the past, whereby I remember when I first started way back as a registrar in the UK, we had to wait months and months for an MRI scan because there was far few available. Now with the availability and private providers, etc., we've got much more access to that imaging and also a greater understanding of those injuries. And so we can pick them up more readily. We've got more access to imaging, and we've got a higher expectation of being able to get back to sport and playing and availability of it. And that kind of expands from that point of view. So we've got people who've got an expectation to be able to maintain their sporting abilities and also to later life as well. People want to stay active much later in life now than they did previously and still remain active. So that's why potentially we've got on a multitude of levels, we're able to diagnose more and we've got greater participation, which overall is probably good for the health of the nation.
And that's certainly my experience coming to this country, that we're a very, very sporting nation. And, I come from overseas and I thought that I was quite good at tennis. And then I arrived here and it was like, no, I'm not actually, compared to all these Australians. How do ACL and meniscus injuries typically present? And what are you looking for when you're examining someone?
Yeah, well, so, there's two things that they really look for. Ligamentous injuries. So basically, when you have a ligamentous injury whilst playing sport, and generally we're talking about the acute presentations of both, you will generally get an immediate hemarthrosis. So it's the timing of that. So it's a sudden, severe pain. You often complain of a pop or a sudden feeling of the knee giving way, and it will swell up almost immediately. Now, it doesn't always, because in medicine we can never say always or never. Okay, I used to say that, in MCQs. If it says always or never, it's false. But generally speaking, it will present with an acute hemarthrosis and done that. And if that's happened, generally that only happens if you either have a fracture or a ligament injury. It is possible to get an acute hemarthrosis with an acute meniscal injury if it's significant enough to go into one of the vessels, the geniculate vessels that come into the back of the meniscus. But generally, that hemarthrosis or swelling will take several hours, if not to the next day, to develop. After the acute swelling, as that settles, the knee will generally then feel unstable, and you'll often say to patients, does it feel unstable? And they'll say no, but I was speaking to a guy the other day. I said, does it feel unstable? No. I said, but will you sidestep on that knee? No, 100%. No, I wouldn't. I would give way. Could you run on the beach with that knee? No, I wouldn't do it that way. And that's their dominant knee, and then they won't sidestep with it. And that's what you're saying. You don't trust it. You don't trust the knee, and therefore that's the more instability. And that can feel that's generally ligamentous, but again, it could be with a meniscus if it's catching. Catching and locking is what we really generally feel with a meniscus. So in a twisting rotational movement, we'll feel a sudden sharp pain, and that may make the knee give way. There are obviously other things like patellofemoral problems which can present in a similar manner. And do that. The one thing we really want to pick up on is the really significant, severe multiligamentous injury. And they would generally present with significant pain and being unstable, and they need to be picked up relatively early. So if anyone's doing sort of pitch side stuff, if it's a sudden severe pain and swelling, there's any concern about neurovascular injuries, so the nerves not working, because there's a high incidence of nerve and vessel injury and knee dislocations, which are very significant and severe, very rare, but can happen. In those patients, they want to be treated in an emergency fashion.
And aside from that, when should you refer someone for urgent imaging or urgent orthopaedic referral?
Well, I guess the acute severe hemarthrosis is an indication that something much more significant has happened, and that should probably be more urgent imaging in terms of MRI scan. The useful investigations in the young patient, it's worthwhile getting plain X-rays just to make sure that there's no obvious fracture, but then an MRI scan. Ultrasound, probably not worthwhile, although it's easy to get. In CT scan, again, unless there's any fracture, CT scan's not necessarily worthwhile. As the patient gets older, it's more difficult to get the MRI scans. But if they've got an acute injury and acute swelling, then it is, there's still an indication to do that, but it may be more difficult. So what one can do is get what's called 4-view knee X-rays. And they're an AP lateral Rosenberg and skyline patella. And a Rosenberg view is when you get the patient to stand and bend their knees at 30 degrees and they take a PA view, and they will show early arthritis. So if someone's got significant arthritis or bone-on-bone arthritis, and the reason for that is that in full extension, you kind of roll up on your anterior horns of the menisci. So when you look at the X-ray, you can see a pseudo gap there. So it looks like that's okay. But as soon as you flex down to the 30 degrees, you will see that they'll roll off that meniscus. And if the meniscus is deficient and they've got cartilage loss, then you'll see that. And so maybe they don't need an MR, but doing that. So in the acute setting, those ones with the hemarthrosis, slightly more delayed when it's been more acute, we're looking for the axial loaded unstable meniscal tears. And they're the ones that we probably need to treat a bit more rapidly. And that would be a complete radial tear or a root tear of the meniscus. And that will often happen. It can happen in the young active patients, and there are things that we want to do, but they can happen in an older population with a slightly degenerate meniscus. But if it's a complete radial tear, that defunctions the meniscus straight away. Or a root tear, and they'll often present with a sudden severe pain and then locking or severe pain, often they'll feel a root tear at the back of the knee, sudden pain at the back of the knee, been going great and it's sudden severe pain and no symptoms of arthritis beforehand or maybe a little bit, and do that. And then if their X-rays are normal, then we can get an urgent MRI scan, because they're the ones that will go on to progress to get arthritis more rapidly.
According to the Australian Sports Commission's Ausplay survey, nearly 85% of Australians aged 15 and over took part in sport at least once during 2023-2024, with almost half participating 3 times a week. Around 19% of these active Australians sustained injuries, more than 62,000 serious enough to require hospitalisation. Falls, including collisions, slips and trips, caused nearly a third of these, while transport accidents involving bikes, motorcycles or animals accounted for almost 22%.
You have a strong background of working with athletes. Does the type of sport influence what sort of injuries people will get?
Yeah, my son's really into soccer and a runner, and my daughter was into rowing. So, and being a parent on the sidelines, see lots of different injuries, looking after their teams as well as the more elite teams. And you get different injury patterns from both across country. We get a lot of stress injuries, stress fractures, overload, not managing their nutrition, and sudden increases in load when they go through growth phases. So managing those and getting the young kids like off their or resting or doing pool running, or because they still want to keep fit, and doing alternative exercises so they don't propagate and get full fractures. And so you manage those things conservatively. You can see more sort of different types of knee ligament injuries in different sports. I mean, I see all things from like motocross, cycling, soccer, football, AFL, rugby. Obviously, rugby, we see more upper limb contact things. AFL, we'll see high ball, a bit more because you're going up for the high balls and landing. Basketball players, again, ankle injuries and knee injuries. And it's a whole spectrum. So it's different types of different things for different sports. And then different expectations of getting back for that as well, for different reasons.
What about age? So my husband is in his 40s and he plays touch footy, and it seems that every time he goes and plays, one of his mates or my husband get a hammy injury. Is what happens with age?
Yeah, well, I mean, aging's, well, as we say, birthdays don't happen by themselves and age doesn't happen, I mean, things like our menisci, I used to say, why do we get meniscal tears more than the other? Well, when you're younger, your menisci is like a bit of calamari, okay? So, I mean, that's just a tissue. It's one of the tissue examples. It's like a little bit of calamari, but it's like when we're young, it's like Michelin star calamari, it's nice and pliable. It's, beautiful, excellent. And then I probably can't use any names, but a pub grub a calamari, by the time we get older, it's a bit more brittle, a bit more rubbery. It's still great, but still works. But depending on the pub you go to, I guess. But it's a bit more brittle, so it's more susceptible to injuries. Essentially, as we get older, our skin's not as good, our turgor changes, and as we get over, it's 27, we're actually on the decline in terms of our tissues. So we're more susceptible to things, and also when we have we talk about the sort of the weekend warriors, the 40-year-olds, and we have these kind of almost bimodal injury whereby you have the young super fit athletes who are playing at a high level, not necessarily high level, but super fit athletes or athletes at a younger age playing competitively. And then generally speaking and cyclically, people will then have their family, their children. They maybe don't do as much activity around that as they would like to do. And then later in life, they come back to it. So they've deconditioned. They've maybe not remained as sport. I speak about myself here. I've had older injuries as well, and getting back into sport. And it's harder to get fit. We know it's harder to get fit when we get older. It's harder to change the muscles. We don't stretch as much. We get stiffer. We probably don't do the other things that we should do, and therefore that can result in injuries. We're not as good conditions, even particularly post-injury. I say it with my older patients in particular, it's, don't go from zero to hero, and that's with your sport as well. We get the people who, couch to 5K, all of these things, we go suddenly and think, okay, right, that's it. I'm going to do everything. And instead of doing a little by little, we go straight into it and do that. Don't warm up. Probably drink more alcohol, and don't look after ourselves as much, and that can result in those injuries.
Mike, what role do supplements have in the preservation of joints, or also symptom control?
Yeah, I mean, I guess there's not lots and lots of evidence about supplements to do that. It's really important for people to be nutritionally balanced. The key things is to to have a good nutritional balance, good weight control, to not be overweight. If you're diabetic, borderline diabetic, to have a well-controlled HbA1c, and to be a non-smoker. All of these things help, particularly when it comes to both the joint preservation and surgery. There's lots of evidence or lots of things about supplementation, and people talk about things like turmeric, manuka honey, fish oils, and there's not much evidence there. My dad, who's got an arthritic knee, swears by manuka honey, but there isn't much evidence that actually has a significant effect on anti-inflammatories. There is some evidence about glucosamine sulfate. It's not strong evidence. There's mixed studies. There's a study out of Sydney, which looked at MRI scans and showed a slowing down of the cartilage degradation progression. But in that particular study, there wasn't much difference in symptoms, but there are some studies that show that. So it probably doesn't do any harm. So therefore, it's not bad idea to take that. But the other supplements probably isn't a huge amount of evidence for.
You're known for your work in preservation surgery. How does this apply to ACL and meniscus injuries?
So, I mean, I guess preservation surgery is essentially trying to preserve the structures that have got there. I mean, first and foremost, you need people to be fit and healthy and active and maintain their muscle bulk and all the rest of it and all the ancillary things that go along with that. So we try to, keep them as healthy as we can. And then on top of that, preservation surgery is like, I grew up in an era whereby we did meniscal debridements, meniscal, everything was, you just trimmed everything back. My dad, when he was growing up, was a semi-professional footballer. And there was a surgeon in the UK called Smiley who had a Smiley knife. It was a curved knife, and he used to do this big incision at the front of the knee, pull the meniscus forward, and then cut it out in one fell swoop. And my dad, clearly, when you look at the injury patterns, probably had an ACL injury when he was playing football and was told it was probably his meniscus, had an open incision, had the meniscus pulled out, and at the end of the jar on the end of his bed at the time, there was this meniscus lying there. And he said, "Here's your meniscus. It wasn't too badly injured, but you don't need them anyway." And nothing could be further from the truth, really. And strangely enough, he's going for his knee replacement later, so this year, and has had a bad knee for many, many, many years, and has probably needed a knee replacement a long time before. But we really want to preserve those structures. They're the cushions, the shock absorbers, and we've got lots of tips and tricks to do that. We can use little blood patch supplementations to get the meniscus to heal, where we take a bit of the patient's own blood, and we make a clot out of it, and I cut it into little strips, and we can then use a suture and parachute that little clot into where the tear is, and then suture around that clot. So it kind of helps to glue the meniscus essentially back together again, because the synovial fluid flowing around the joint can stop that from healing. We can do things like ACL repair now. The evidence is mixed with regards to that. But also identifying injuries earlier, so we can then manage things conservatively or protect the knee, so we don't get any further degradation with regards to that. The other thing is as well is in terms of preserving the actual joint itself. If you get slight malalignments or wear and tear in one pattern, then we can do things like realign the knee joint to preserve their overall alignment, to stop progression of wear. And finally, whilst it's not preservation, I'm one of the few surgeons who does meniscal transplants. So we can actually transplant menisci in, which will help to preserve the cartilage and hopefully stop the degradation to lead to arthritis. And that preserves them with their own knee, which generally will function better than a joint replacement.
How do you decide the person who gets the transplant? Yeah. And how difficult is that process and the recovery?
Yeah, well, I mean, we talked a bit earlier in the piece about each patient's an individual. So like I do a talk about, there's a smorgasbord of knee operations or rather knee treatments. Mm-hmm. So it's trying to decide the right treatment for the right patient at the right time. And that's different in each individual for each individual's process. And trying to decide that is both a discussion. None of these operations are life-saving, essentially. They're all lifestyle altering. Or treatments, and it's about improving the patient's lifestyle and timing it with their lifestyle as well. So there's no good saying we need to do a big revision surgery if it's going to mean that the patient can't go to work or can't earn an income, but it's doing that timing so they can do that for them whilst doing it early enough so we don't get degradation. So it's really that discussion with the patient. Age does have a factor, so the older one person gets, then the less likely we are to be able to repair, because our tissues don't repair as well. So 50 and plus is a bit of a cutoff, but actually, I've done some preservation surgery in older patients than that who've been physiologically very fit and young. So chronological age isn't necessarily a thing. Physiological age is probably important too.
What if you've got an older elite athlete? So elite versus recreational. Where does it sit then?
Yeah, well, I mean, I guess, the older we all get, the more elite I think I was and am, we all look reflectively back with rose-tinted glasses, and it's about an individual basis. So there's a big difference between elite and recreational athletes and timings and things like that. Sometimes with elite athletes, we are You're trying to get, if they're towards the end of their career, you're trying to get them through the season. For example, the recent Lions tour, for example, if an athlete had come in who was the last chance to play against the Lions, never going to play in the next 12 years, you might decide to do something more conservative to keep them going, or do a meniscal debridement because they won't get through the recovery for a repair prior to being able to play that. And then you've got to deal with the consequences afterwards. So you might have to manage them slightly differently to a recreational athlete, and because of the implications of salary, job, etc. But then the recreational athlete's got their salary, job, etc. but in their other life, not their recreational life, but you want to maintain them doing the sport. So it's that having that discussion with the patient, what is optimal for them at that time in their life, and if they can go through the procedure or not, or whether we have to manage it other ways to do that. And it's the key thing is it's a co-decision between you and the patient as to what's going on. I can give them advice, but it's ultimately the patient's decision as to whether or not we do something surgical or not.
What are the current best practices for ACL repairs and meniscus repairs?
Yeah, I mean, if you just put through that into a room of knee surgeons, you'd get a debate, and there's whole conferences to go to, weekends with regards to that. We'll often argue about the pinpoint accuracy of where the ACL tunnels and things should go. I think with regards to meniscal repairs, particularly young patients, lateral meniscus, they're ones that really probably need to be repaired. And that's due to the anatomy within the knee joint. So the tibia on the lateral side is convex, and also on the femoral side is convex. So if you lose the dish effect of that meniscus on the lateral side, you'll get point-to-point loading, and there's evidence that suggests that the pressure of that, particularly if someone's valgus, is greater than the pressure that the cartilage can take, and therefore will progress to arthritis very rapidly. It comes to mind a 23-year-old patient I've got at the moment who had a lateral meniscectomy in his previous, before he came to see me, and an ACL reconstruction, but has now got significant arthritis on the lateral side of his knee joint at a very young age. We're going to have to try to do things to correct his overall alignment, possibly a meniscal transplant to do that. So in terms of state of the art, you want to try and preserve, like we talked about earlier, they want to try and preserve the tissues. In terms of ACLs, there is a vogue for coming into conservative treatment of those. Now, again, like all the operations we talked about, none of them are life-saving, so they don't have to do them. It's about how they fit into life. But if you're someone who does a pivoting sport and you are unstable, then I think it's reasonable to consider reconstruction of that, or repair if you can get them early. And there's very limited indications in terms of it needs to still have a good length. So mid-substance tears of the ACL probably aren't amenable to repair. But there's lots of advancements going all the time, and there's lots of evidence and mixed evidence other ways. People have chosen different grafts. Why do some people choose a quadriceps tendon, hamstrings tendon, patella tendon? Whether we should do a lateral tenodesis in combination with that. And there are consensus groups that have come up with things. Recently, a consensus group on meniscal repairs, and there's good evidence now that actually economically meniscal repairs are better longer term than debridements or conservative management in certain population groups. ACL, lateral tenodesis, which groups to do those in, the revisions, the young patients, we've got a high incidence of re-injury. So it's working out that individual with a basis, and I've specifically been getting what's the state of the art. Well, it's the state of the art is for that particular patient and what their aims are to get back for, and having that discussion with them.
You've talked about so many advancements that we've seen over the years in various areas. What about robotics and navigated arthroplasties? Have they changed the game in knee surgery?
Yeah, I mean, look, so when I first started doing arthroplasty, we used intramedullary alignment. In fact, in some of the places we didn't really have a medullary alignment. It was sort of extramedullary alignment as well, which was actually in some respects still really accurate and still give excellent results. What the tools in terms of robotics, and they've moved that and over onto navigation and robotics, is they help provide us with a bit more accuracy and delivery of the implants, to be able to put those into place. It's still, you still have to be aware, like, although you put things into a computer, it's like I tell the trainees when we're going through, you put the numbers in a calculator and make a sum, And at the end of it, you go, hang on, that can't be right. And you look at this, shouldn't be right. You need to be aware of where the implications of putting the implants and things in are, because if you put the wrong information into something, then it will give you the wrong information back. It won't tell you this is now. AI software is coming into it's not there yet, but there is movements into to help with those things. The other advantages are they help look at the soft tissue balancing, and that's the key area. So we used to put all joints level with the joint line, but we know that everyone's legs are different shapes. They move into different shapes when you go into flexion. So some people are a little bit bow-legged, some people are a little bit knock-kneed, some people are straight, some people have higher flexion and change as they do that movement. And we can look at those movement patterns with the robotics when we use that in terms of navigation. And we can then use that to help to balance the knees better. So the knee then behaves potentially more like the patient's normal knee to do that.
Can you share your insights from your experience doing revision surgeries and what makes them more complex?
Yeah, revision surgeries, it's always difficult. And we say that to patients as well. Once we go down the metal route or revision, so particularly with revision arthroplasty. So there are two types of revisions we're really going back to there. There's revision knee ligament surgery. So I guess when somebody's been there before, there are different tunnel positions, there are different areas, and you maybe don't have the same abilities to go back exactly where you want to do. And it's like rather than building a house from scratch, you're doing a renovation, and it's more complicated because therefore you're going where someone else has already been, and you've got to make some compromises because you can't quite do what you may have done in the first instance to do that. And also, if you're revising, the first one has failed, we need to figure out why it didn't work and try not to do the same thing again. Is it serendipitous? Is it unlucky? Or is it something technically that we could do to improve in that particular patient? So in terms of knee ligament surgeries, we need to look at different tunnels. We need to potentially use a different graft. Your choice may already be gone and do that, and then augment that so the same thing doesn't happen again. With arthroplasty, again, we need to figure out why it failed or why it's not working or why it's still sore. And then again, you're going in through scar tissue. There's been surgery that's already been done. There are greater risks of infection and complication with revision in terms of doing that. So we've got to it be technically more there. And then you're not going in through normal anatomy. You're going through things that have been there before, and there's less of the structures available to then balance. We need to think about how we balance, how we manage any of the defects and do that.
According to the Australian Institute of Health and Welfare's Sports Injury in Australia report, in 2023-2024, hip and lower limb injuries, including knees, were the most common sports-related hospitalisations, especially among young adults, accounting for 17,600 cases or 28.3% of all incidents. Shoulder and upper limb injuries rank second, followed by head and neck trauma.
Mike, what does your research show about improving post-operative outcomes and speeding up that return to sport for the recreational and the elite?
Yeah, look, I think there's a lot of stuff we do in order to improve those things. Even simple things like we use little push bikes, little tiny push bikes. They cost like $40 from Target to be able to do that. So
how tiny? What are we talking?
So little floor pedal cycles with little like metal triangles. I call them sometimes call them little old lady bikes, but it doesn't go well when you got your elite athletes saying that. And you get them like you have to tell them, we're not training you for the Tour de France after this, or in terms of the elite or the higher level athletes, they want to put high resistance on and really build their muscles up. The important thing really is getting post-surgery is getting a quiet knee. Simple things like 20-20-20. So subdividing their time in 20 minutes of rest, 20 minutes of ice, and 20 minutes of exercise to get the knees moving, but without overdoing it. So one of the key things is, like all the things, we want to get the Goldilocks amount of things. We talk about the Goldilocks amount. So it's the just right amount of activity, rest, and analgesia and icing to do all of that. So it's trying to work that out individually for patients and trying to make the people who do too much slow down a bit, and the people who don't do enough do more. And it's trying to get that in to do that. So by using things like simple pedal cycles, using ice in certain times, using certain anti-inflammatories, things like tranexamic acid have helped with the bleeding and inflammation afterwards, the operation. There is ERAS protocols around joint replacements now, which can enhance. There's a sort of enhanced recovery, so we can utilize those to get patients mobilizing faster, so we can get them up the night of surgery and get them walking the next day, and hopefully get them sooner. We're looking at different approaches, different skin incisions. So if we make a skin incision a bit more laterally on a knee replacement, it preserves the sensation on the front of the knee, potentially gets people kneeling faster. There's all those, and it's, I used to play rugby, but then I got into cycling, and there was, when Team Sky came in, they talked about the 1% gains. And we're looking in lots of things in surgery we do really well. And some things will change, some things don't, but each little thing can give us a little 1% gain. It's looking for those 1% gains, 1% changes, or some cases more than that, but the little changes, and that all adds up to a better improvement for the patients and a faster recovery.
What are the typical timelines when it comes to recovery that GPs can keep an eye on? And I guess the other question we get from patients is, when can I return to work?
Yeah, I mean, that's difficult. So again, it depends. It's individual basis on the surgery. I always say to patients with knee replacements, you're going to hate me for about 6 weeks. You're going to think, why did I ever listen to that crazy Scotsman, and why did I ever get the operation done? And you've got to be careful what you say to patients. Because I used to say, one of the things I always say is, you'll not like me for 6 weeks. And after about 6 weeks, you'll put the voodoo doll back in the drawer and you'll start to forgive me. And one of my patients, actually, I went into the ward and I'd done both of her knee replacements and one of her husband's knee replacements. And he'd had the other one done before. So they'd all had their knees done. And actually, I think I did one of their hips as well. Both of them had quite significant arthritis. And when I went in for the last knee, she was sitting there and she's got a present for me in a box, and there was a voodoo doll sitting there with Dr. Reid written on the back and pins in the knee, and she said, hopefully I won't need this anymore because we've all had our knees done, But it's very sweet, but she'd obviously heard the spiel a few times, but it's true to a degree. I mean, obviously, like we talked about, we're trying to improve those 1%, so we're trying to make it as comfortable as we can for possible. I've had other patients said, I've got a bone to pick with you, Dr. Reid. You said I was going to be not like you for 6 weeks, and I only didn't like you for one, Unfortunately, everyone doesn't say that, but do that. So 6 weeks really for joint replacements and inflammation, and doing that can be a bell-shaped curve. So again, some people better than others. With driving, they're not going to be insured or are not going to be able to do that for between 6 and 8 weeks. Okay, and they shouldn't drive, particularly with the right leg, until they can do an emergency stop at 60 kilometers an hour. And the consequences of not being able to do that don't bear thinking about. The left leg, once they can get in and out of the car, if it's an automatic car, they may well be able to drive, but they need to be off the stronger painkillers before they get into driving. And getting back to work is partly dependent on what job they do. Similarly, with meniscal surgery, can actually take a little bit longer, because in terms of, we may need to keep them on crutches for up to 6 weeks afterwards. Particularly, we talked about those axially unstable meniscal tears. So we want to keep the weight off of those, because obviously, whilst I've stitched it back together again, if you just put the weight back in, then it can cheese wire through or can re-tear. So you've got to be a bit more conservative with those and protect them weight bearing. And that can take a little bit longer to then get back, but then the longer term benefits are there. So it's just about, again, like we talked about, the individual patient basis for those. I guess with any GPs, if they are concerned post-operative with a patient, I give them a letter immediately about the operation for the patients. And then we'll see the patients for follow-up. But if there are any concerns, I say to my patients, I'm here to worry, not you. Okay. So if they're worried about anything, they get in contact with me or their GP, or the GP gets in contact with me. And then we'll make a plan and we'll say, look, this is something we need to worry about. Yes, come in, we'll sort this out. We wrap you in cotton wool, we'll look after you. If it's not something they need to worry about, or it's something that's relatively routine, then we can reassure them and tell them that that's okay. Because as I said, I'm the one who needs to worry, not them.
Mike, thank you so much for your time and your expertise. It's been absolutely fascinating. I feel that we probably need to get you back at some point because there's so much happening. But before we let you go, we've got a little surprise for you. We've got something we like to call the checkup. So Maria's got 5 quick questions for you, meant to be a quick 5. And it's to really get to know you as a person as well as a professional. Are you ready to go?
Sure.
All right, Mike, what's your surgery playlist?
My surgery playlist, combination between, I've got a cycling playlist and a Scottish playlist. So I've got some Scottish artists that play on that playlist, and I've got some cycling ones which are a bit more upbeat. But sometimes they like to have a bit of a chilled out playlist as well. But I have to get in there quickly because I've got some anaesthetists who've got some very good playlists as well, and they like to play theirs as well. So, and obviously I can't change it once I'm scrubbed. So it's good. But it's a fun environment in theatre when we get to listen to music and stuff, and it makes that an enjoyable experience for everyone.
How do you want patients to see you?
So you could answer that question in many different ways. See me, if you ask to answer it, it's how they want to see me as a person. I'm a nice, friendly guy who is kind of very compassionate and can bore anyone to death about knees, but I'm really passionate about what I do, and I enjoy what I do. So hopefully that passion gets shared over to what they do, and it improves the outcomes for their care, not necessarily operation, because we don't do operations for everyone, but we do that.
What's your superstition?
I always wear some pink. Pink's my favourite colour, so I always have to wear some pink. I've got pink theatre shoes, there's pink in my logo, I have pink stuff in my cycling gear, so I always have to have some pink on, so I guess that's my superstition. I now even have some pink socks that I try and wear as well. So yeah, pink's probably my superstition. I mean, there's other little ones, you can't break the surgical cheese, so when we do things a certain way in theatres, I do them a certain way because it seems to work for the results that we do. But pink would probably be my superstition and favourite colour as well. So if that's the next question, then I've already answered it. But
if you weren't doing this, what would you be doing?
Oh, well, when I grew up, I thought I was going to be a professional rugby player, but I went and played a rugby season in New Zealand and realised very quickly I was better being an orthopaedic surgeon than I was being than being a rugby player. Learned the hard way, and I was very much educated in my abilities. So I guess I'd love to do that. But I mean, I'm probably that's why I manage sports and things now. I enjoy sports, and I would have loved to have been a professional athlete. I've played at a high level in Scotland, but never played for Scotland and did that. But I think I'd love to be. I'd have loved to have been an athlete. I'll stick with being a weekend warrior cyclist these days.
What TV show best portrays your profession?
Best portrays our profession? Gosh. I don't know. I don't watch many of the medical ones. I guess from that point of view. So I don't watch many of the medical shows because some of them used to frustrate me when they got things, medically inaccurate and things like that. I used to watch ER when I was growing up, but a patient. This is probably an embarrassing story, but a patient did say once, and I'm definitely not good looking, but when she came into theatre, she said, I didn't realise it was going to be really like ER when I was a younger doctor. It was obviously in my younger days before I lost hair and everything else like that before I got married. But yeah.
George Clooney.
Yeah, well, so I was the Scottish doctor in England at the time. They called it so that my nickname for about 6 months was Dr. McDreamy. She wrote that. But I certainly am good looking. So I think it was probably more says something about the patient than me. But probably ER was the one that I would have watched when I grew up, and I kind of got into medicine and a little bit anyway. But that's probably it. But I don't watch many of the medical dramas these days.
Thank you so much for joining us on sMater, Mike. It's been great.
Thank you very much for having me, and I hope it's been entertaining and useful for people listening.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.